With the information presented in this patient's case, I came to the conclusion that the patient suffered from the neck pain classification variety known as coordination impairment, also known as WAD, whiplash associated disorder. And the main tell of this conclusion is the way she suffered the trauma. She was having a skiing accident. Someone struck her in the back, having her head snap backwards and forwards, which the main impairments that this causes is to your flexors and to your range of motion from mid-range on. Now, her neck flexors were her poorest scores. She was 25 actively and 30 passively out of 45. That was her greatest pain level, 6 out of 10. Also, her cervical rotation is also worth noting. She got 48 on her left and 50 on her right, which, and also 55 passively on each side. And the fact that she couldn't even reach active range of motion norms of 60 on each side, she couldn't even achieve that passively. There is some tissue resistance there at mid-range, which not only helps me come to the conclusion that she suffered from WAD, but also the fact that she's still in the acute phase. Also, another big tell that she is in the acute phase is the fact that she is suffering constant discomfort without even moving her neck. That it has acute written all over it. Now, the pain is 2 out of 10, so I feel like subacute is in the horizon, as well as the fact that she is not suffering from other certain impairments that certain patients of this variety suffer from, mainly being heightened emotional distress, heightened sensitivity to certain senses like touch, mainly thermal type of touch, smell, light, and sound. However, every other indicator shows that she is definitely going through whiplash associated disorder. And another tell that it is of the acute variety is her very poor neck disability index score, which is 46%. 50% is labeled severe, so she is teetering on the severe levels. So that alone, I wouldn't feel comfortable putting her through subacute interventions quite yet. Another thing worth noting is she had intermittent headaches, which is, again, another indicator of coordination impairment. Now, typical symptoms of this type of neck pain classification is, again, headaches, which she is getting intermittently, dizziness, nausea, lack of ROM from mid-range on, as well as, again, heightened sensitivity to touch, sound, thermal type of touch, like hot and cold, sound, hearing, light, and, strength and endurance issues to the neck, which also, she also had a very poor neck flexor endurance test. 12 seconds, which is showing very weak neck flexors, very weak endurance of the neck flexors, as the average woman is supposed to be able to hold for 29 seconds. So that really helps me justify the conclusion I came to for this disorder. Common interventions that I would teach this patient, as far as educational purposes, is, trying to do everything as normally as possible, as much as possible on her day-to-day life. She goes to school, she's very active, she's trying to get back to self-defense classes, She even tried to finish skiing when she got hurt. So just kind of maintaining that same spirit of trying to maintain her range of motion, but at the same time not trying to do too much to re-aggravate her injury. So I guess I would say something like trying to find that middle ground between the two. Also, if she was presented with a neck collar, I would, encourage her, use it for the 6 weeks that it's usually implemented to patients of the acute variety of this neck pain classification, and wear it as little as possible, only when you really feel like you need to, because you don't want your neck to stiffen up. The idea is to get her moving again as much as possible. The neck disability index relevance, as I touched on, she got a 46%, which is moderate but kind of bordering severe neck disability. And that, again, I would try, to avoid subacute treatments until we get that score at a better level. Deep neck flexor endurance test relevance, again, just further justifies her sense of her weak neck flexion, which, it's putting your head up, tucking your chin while having your cervical part of your spine in extension, trying to hold it as long as you can. She's very unable to do that right now. So until we get that score better, definitely keep her in the acute swing of things, which is just maintaining her range of motion through active range of motion exercises, excuse me. Patient education, rather, interventions as well as education that I would provide to my patient would be, since we're in the acute phase, not too much we can do at this point, just besides, again, just maintaining range of motion, improving those range of motions through active range of motion exercises. Just also educate her that it's okay if you are feeling those like heightened sense of emotional distressive vibes. That's totally normal in her case, and to just fight through it and just keep promoting that positive mentality of moving forward with the recovery. And then once we are able to improve on that range of motion, just looking forward, the outlook of things, we now be in subacute. So now we try to integrate maybe some isometric workouts to further strengthen her cervical level of her body, as well as starting to work on some of the other things that were bothering her. Another thing worth noting that I haven't mentioned yet is her abductors were also pretty hypomobile. 150 to 155 out of 180 is very much hypomobile. Her shoulder flexion wasn't as bad, very slightly hypomobile. Maybe we can touch on that a little bit, but her abductors were definitely worth something to consider as far as strengthening once we do get to more involved subacute workouts. Once we get to chronic, we can now start working on more functional types of interventions. Like, one thing these patients of the coordination impairment suffer is mainly their sense of lack of coordination. So not just range of motion issues. So once we're trying to get her functional ability back in order, we're trying to get her to recruit all the right muscles in the right order, getting her sense of just doing everything with the right flow. like maybe for perhaps taking a laser and pointing at the wall and having her neck move with the motion of the pointer. Maybe even taking her hand, abducting it, flexing it, also abducting it, pointing it at the wall where the laser might be. Certain things like that to try to help with not only her range of motion, but her sense of coordination as well. And also just further educate the patient that, hey, you are in the recovery phase. We're now in the chronic phase. So things are going to get better. So when you feel like your body might be breaking down, you might be really feeling like you're going through it, like you're going to re-injure yourself. Hey, we're past that. You're going to get better. Just keep encouraging her that things aren't going to get worse. They're going to get better. You just got to keep going through these motions. Your body is now building itself back up, and pain is really going to be the main thing to get past as your body is starting to loosen up due to the other interventions. TENS unit, that's another thing that we'd be maybe giving her in the chronic phase. And if we did, I would try to encourage her to use it only when you really feel like you need to. And that could be very subjective from patient to patient. This patient, again, seems like a trooper. So seems like I would try to, if she was able to keep her sense of pain level low in her head, despite having very limited ROM and very limited range of motion at the phase she's currently in, without even, she's already feeling discomfort from sleeping, unable to sleep, unable to move her head without already feeling some sort of sense of aggravation. Just letting her know that TENS unit is really only when you really need it. So now going into actual workouts, the thing that I would try to attack in a good way, of course, would be her neck flexors. We want to improve her neck flexion more than anything, because that's what's suffering the most. But other things that are limited are, again, her lateral flexion movements on each side, her cervical rotation on each side. Those are both things that I would try to improve upon. Again, shoulder abduction, probably in that order, as far as prioritizing, with cervical flexion as well as lateral flexion as well as rotation. Those things I would integrate equally, but the flexion is definitely the thing we're trying to worry about the most. Literal workouts that I would suggest for her is, hey, her neck endurance flexion test was very weak. That is a workout we can mimic and get her to improve upon. So just whenever, I would just have her at home a few times a day. Whenever she feels like she just has some downtime, just place her neck in extension and cervical extension, and then tuck in her chin, and then maybe just put her hand down there and try to just touch her fingers, or maybe just use her collarbone as a reference, and just try to break her record. She got 12, so over time she's going to beat that. I would just encourage her, beat that 12 score first, and then once you're past that, I would also have her lying supine too, if she really wants to actually mimic the test. But, just something's better than nothing. So even if she is not in a position to be able to lie down somewhere, just try to work those neck flexors as much as possible. And another workout that I would incorporate, in my opinion, kills two birds with one stone, because she's suffering from lateral flexion and cervical rotation, and as well as flexion. So why not just put your head down like this and start rolling it side to side? Seems like you're kind of isolating each of those movements, because you're doing this, you're doing this, and you're doing this, just all kind of in one motion. And since we're trying to get her endurance up more than anything, as we're still in the acute phase, we're not trying to provide much resistance, just more active range of motion. I would just have her do 5 sets of 8. As 8 is kind of that intermediate entry level of endurance sets. Once she feels more comfortable, maybe 10, 5 sets of 10, 5 sets of 10 motions, one way, back and forth, counting as 1, and just doing that until she's ready for the next phase, which would be subacute. And that's how I would treat this patient.